Good morning. I'm Terry Roselle from the Department of Bioethics and the Center for Practical Bioethics, and I welcome you and all of those who are coming in via Facebook or other social media technology or watching on YouTube. Welcome to Current Issues in Bioethics, a lecture series. This is the 8th lecture, the last lecture in this 3rd annual Current Issues in Bioethics lecture series. So we welcome you all, and especially students who are here as a part of their course as well. About a decade ago, I was driving around a just graduated PhD, young up-and-coming scholar, driving him around Kansas City on orders from my boss at the Center for Practical Bioethics to try to recruit him to come to Kansas City. I failed at that task, but we were right that Daniel Goldberg was an up-and-coming scholar, a rising star in his fields of study. And we got him here today, not to stay, but as a guest lecturer. Dr. Daniel Goldberg has a PhD in the history of medicine. He did a JD before that, so he's also got a law background. He comes to us today from the University of Colorado in Denver, where he has appointments at the Anschutz School of Medicine in Department of Family Medicine and also the Center for Bioethics and Humanities. Daniel does teaching, publishing, continued research and studies in areas of pain, chronic pain and ethics, areas of public policy, law and medicine, and of course bioethics. And today he comes to address us regarding the topic of stigma in health and healthcare. Please join me in welcoming Dr. Daniel Goldberg.
Thanks, Terry. Is this on? Can you hear me? Yes? We're good? Okay, awesome. So thanks everybody for coming. I know some of you have to be here, but thanks for coming anyway. So especially those of you who choose to be here and give your time, I appreciate it. So I'm going to talk about health stigma, and this is probably my central area of research over the last 3 to 5 years. I'm particularly interested in stigmas that attach to non-communicable and chronic illness. So that's where I come at interests in pain stigma. The other one I spend a lot of time talking about is weight stigma. In particular. I won't talk too much about either of those specifically, but those are the areas that I really sort of focus in on. So understanding health stigma in clinical settings as a key to preventing it and thinking through some of the ethical, legal implications. And just to sort of expand so you understand where I'm coming from, I mostly think about things from a public and population health perspective. So I self-identify as a public health ethicist. And part of my interest is thinking about the connections between public and population health approaches and clinical practices. You know, what would it look like if we integrated public and population health concerns into clinical practice? And that's the vantage point that I come through from sort of stigma. Okay, so I always try to teach their learning objectives, so this is what we'll do. You can see the 3 there. Usually whenever I present on stigma, which I do quite a bit, I usually say even if we only get number 1, I'm actually pretty happy. So even if you don't walk out of here, we will get to the other 3. But even if you walk out of here with nothing else other than an understanding of what stigma actually is, I'm actually pretty happy because most people don't really know how to define stigma. It's one of those, well, it happens when, you know, or I've seen it in this case, or more likely, I've experienced it when. But I actually think when we start to understand what stigma actually is, we can get at some pretty important points. And that's what I'll sort of be talking about today. So what's the criteria for stigma? We'll jump right in. What is it? There's a huge literature on stigma in the social sciences and the humanities. And that's why I partly think it's important to sort of take a look at what is said there. It's not simply prejudice or bias. It's not simply prejudice or bias, and I'll say a little bit more about why it is. It's obviously, pretty obvious I think to most people, it's connected to prejudice or bias, but it's not exactly the same thing, okay? Why? So the sort of father of stigma studies is a guy named Irving Goffman, and I actually put his book up there, his title, because I think it's really interesting to look at the subtitle of this book. It's Notes on the Management of a Spoiled Identity. it's really helpful to think about the ways in which stigma actually spoils people's identity. We carry stigma throughout our social worlds. So to be more specific, what's stigma? So I've tracked Bruce Link and Joe Phelan's excellent work on this, and they have a conceptual model with like 6 different things. And what I say is we can boil it down to 2 basic things without doing a lot of violence to their model. And stigma is difference plus deviance. That's it. There you go. We're done, right? Learning objective number 1. So what do I mean by that? So stigma happens when you have an in-group that marks an out-group as different on the basis of a shared demographic characteristic. In-group marks an out-group as different on the basis of a shared demographic characteristic. Anyone give me an example of one? Yes, this will be some audience participation. Anyone give me an example of a shared demographic characteristic that we use to mark? Weight. That's a good one. Others? Diabetes. Anything else? Skin color? Yeah, right? Lots of them, okay? So one of the questions we want to ask at this point is, there you go, in-group marks and out-group as different on the basis of an identifiable demographic characteristic. Is that stigma? Not yet is the answer. Okay, not yet. You have to have the second prong. The second prong is deviance. Deviance, there has to be a normative evaluative assignation. Someone has to actually judge the outgroup as deviant or inferior or less than on the basis of that shared demographic characteristic in order for us to have stigma. So that's what you have. Difference plus deviance equals stigma. One of the ways to think about this is to think about the disability rights community, right? For many years, for decades, one of the long-standing slogans of the disability rights community, both in the US and in the UK, has been difference without deviance. Right? In other words, yes, we may have different functionings and capabilities than able-bodied people, but don't judge us as deviant on that basis. Disabled people generally know something about stigma, right? So my view is we should probably listen to them, okay? So one question I usually say is, it might be possible to what I call stop the stigma train after the difference prong, right? So in theory, we could have an in-group that marks an out-group as different on the basis of an identifiable demographic characteristic, and we could stop before we proceeded to a negative judgment, right? Then we wouldn't have stigma. We just have difference marking, right? So my question for you all is, how good are we at that? Crappy. Crappy. We're terrible at this, right? And here I speak as a historian. When you think about the history of illness and health stigma in general, we're awful at that. There's almost always slippage. Eventually, sooner or later, when an in-group marks an out-group is different on the basis of an identifiable demographic characteristic, we generally, sooner or later, progress to judging them as deviant. It tends to happen most of the time, especially when we think about diseases that are sort of form processes of stigmatization, are highly stigmatized, so like infectious disease, sexually transmitted infections, those kinds of things, right? Okay. So one of the questions that I sort of wonder about is, why is disease stigma in the West so common? Why is disease stigma in the West so common? One of the ways of thinking about this is stigma is difference plus deviance, right? And so one of the ways of thinking about this is stigma is fundamentally alienating. It's one of the most excluding, alienating things we do to each other, right? So it's about isolation. How well do humans generally do in isolation? Terrible. There's a great study on this if you're interested. It was published in the American Journal of Public Health in 2013. It took a nationally representative data set, right? So the data is from NHANES 3, which is pretty good data. And it actually, not only did it look at how well social isolation predicted mortality, it actually was a comparative effectiveness study. It compared social isolation as a risk factor to the other major killers, which would be what? Smoking, right? The usual clinical risk factors: smoking, hypertension, sedentary behavior, right? High cholesterol, et cetera, right? And so what did they find? Not only did social isolation predict mortality very well, it predicted it better than any other risk factor except smoking, which it tied. So I'm a public health person. As soon as you tell me that anything predicts mortality as well as smoking, I jump up out of my chair, to be honest with you, because smoking is a very, very, very robust predictor of mortality across a nationally representative data set. So social isolation is a major killer, and there is actually increasing effort to integrate that finding into clinical practices. Isolation is starting to crop up on social histories, on screenings, for example, because we know it is a killer, especially for vulnerable populations, right? So Social isolation, we're among the most pro-social creatures on the planet. We do better in community, and yet stigma is distressingly common. The most exclusive and alienating thing we do to each other. Why? So there are a couple explanations. One of them is an evolutionary explanation, and you have to be careful about evolutionary explanations just so for human behavior. You got to be careful with those kinds of things. That's not always a good idea, right? But part of the idea is that while we need to live in community with each other, there are obvious harms and risks to social life. You only have to think about infectious disease for a moment, right, to realize what some of those harms might be. And so part of the idea is stigma has evolved as a powerful social mechanism we use to control some of the risks, right, of living in community with each other. So that's one idea. Okay. Another idea is phenomenological, and here I'm going to do what all good academics do, which is we cite ourselves, right? Because it's all about shameless self-promotion, guys, in case you haven't figured that out yet. You will if you haven't yet. And so one of my explanations is phenomenological. So what do I mean by this, right? So I know you didn't come to this lecture and think we're going to do some Bible studies, but we're going to talk about the book of Job. Okay? And it's not Bible studies, by the way. I'm joking, guys. Okay? The reason we're talking about the book of Job is because we live in a Judeo-Christian society, and so a lot of your patients and the people you end up treating will end up thinking through some of their experiences in this way. So it doesn't have anything to do, you can be a perfect atheist, no faith adherence whatsoever, that's fine, no problem. It's still worth thinking about, right? So for those of you who do know the book of Job, what happens? Trials. Okay, so go back to the beginning because it's a good story, okay? Whether or not you're a faith adherent or not, it's a good story. There's a reason it's a popular story, okay? So there's a guy, his name is Job, and how's he doing? He's doing great. That's the answer, right? And how do we know that he's doing great? What's going on with him? He's got a lot of money. He's doing well. So his career, excellent, right? It's not just about money and career, though. What about his family? How's his family doing? He's doing great, right? He's married. He's got a partner of some kind. How's his partner doing? She likes him? Yeah, she seems to. She seems happy with Job. Kids? Lots. How are they doing? Good. All right, so that's Job. Then the chief mischief maker comes along, right? And he says the same thing to God that Martin Luther King says in a secular context. He says we don't take the measure of a person at times of comfort and convenience, but at times of challenge and controversy. It's easy to do right and be good when everything is going well. Right? We only know what we have in someone when the chips are down, right? So take all the nice stuff away and then see what happens to your righteous Job. Okay, so then what happens to poor Job? All the you-know-what starts raining down on him, okay? I promise we're going to come back to stigma, so just bear with me here for a minute, okay? So all the stuff starts raining down on him. What happens to his business? Yeah, so Job invested heavily in .com stocks in the late 90s, okay? Right? Not a good idea, right? What about his kids? Yeah, so sickness is actually part of the story of the book of Job, okay? So they die. What about his partner? Happy wife, happy life, as the expression goes? No, she's not happy with him anymore. She's displeased. So all that is just the backdrop, right? Then Job asks the question that a lot of your patients, most people dealing with significant illness, will be asking. They may not ask you, but most people think about this question. It's the cosmic question, which is what? Why is this happening to me? Why is this happening to me? Okay, so then Job's friends come along. And they're Job's friends. They want to help Job. So they try to give him an answer to the question. What's the answer? So I spent the last, before I came to Colorado, I spent the last 6 years of my life in eastern North Carolina. And the expression there, we would have put this, is, you must have did something. You must have did something. Right? And there's, of course, dramatic irony, because what do we know about Job? Guess what? He didn't do anything. And in fact, he protests, he remonstrates, right? He said, I am innocent, right? And that's round one. Round two, what question do you think Job has? Take a wild guess. Why me? Why is this happening to me? Okay, Job's friends, round two, what do they say? You must have did something. Say the exact same thing in round two. What does Job say? No, I'm innocent. I did nothing wrong. That's round two. Round three. What question do you think Job has in round three? Take a wild guess. Why me? Okay, he's not getting an answer. He wants to know. What do his friends say in round three? You must have did something. You must be suffering because you sinned. That's what they say. So what's going on? Then what happens is God reveals his presence, and Job is happy. And by the way, there are a lot of theologians who've studied the book of Job because it's one of the most popular texts in the Judeo-Christian canon. And they say that for those people who believe that the actual Bible was written by humans, not everybody believes that, but for those who do, they say that the question is so profound that there's no way the person who wrote the question would have posed what they consider to be such a ridiculous answer. It's a serious question. Why do innocent people suffer? Right? And there's no answer that's really given. The answer that's given in the book of Job is, well, God. That's the answer that's given, right? And for people, again, who think that the Bible was written by human hands, they say this is such an inadequate answer. There's no way that the person who wrote the question is the same person who posed the answer. They would never have done that. They would never have suggested that that is actually a reasonable answer. So what does this all have to do with stigma? Job suffered because he sinned. What's the alternative? Why do good people suffer? Why do children get sick and die? What's the alternative? What's the emoji? Right? There's no reason. There's no order. It's arbitrary. Good people suffer. Children get sick and die. There's no answer. There's no narrative. Nothing explains this. For a lot of people, this idea is completely intolerable. This idea, there has to be some order, some reason why people get sick, why they suffer. And like Job's friends, we often find it in the West hard to believe that it doesn't have something to do with your action. So when I ask you why someone has lung cancer, what do you want to know? Why do you want to know that? Why does it matter? Why does it matter if they smoked or not? Okay, so if you're an oncology clinician, it matters, okay, because you might treat lung cancer differently if it's a sequelae of smoking, all right, than other kinds. But everybody else, by the way, who's not an oncology clinician, we can't get away with that, right? So I ask this question, I teach, and I ask this question to almost every conceivable audience you've imagined. I've asked elementary school students this question, high school students, undergraduate students, pre-health professional students of every kind, attendees, trainees, residents, you name it. I've asked them all. And of course, the audience always shouts out exactly what you guys did. They always say, did they smoke? And then I usually say, well, why? And then I get a little bit of a recoil as people start to say, why do I want to know the answer to that question? Why does it matter whether they smoke? Because why? What don't you want?
You got a good explanation.
Yeah, you got a good explanation. And I don't want, by the way, I don't want lung cancer, just for the record, okay? And so how will I avoid getting lung cancer? I won't smoke, all right? I don't want type 2 diabetes. How should I avoid getting type 2 diabetes? I will exercise and eat right and do these all things. That person has type 2 diabetes. Why do they have type 2 diabetes? Because they don't exercise and they don't take care of themselves and yada, yada. I'm not saying that's actually true, by the way, guys, right? I'm saying those are our reactions, common reactions in the West, common reactions in American society. So this idea of why stigma is so common is what I call phenomenological explanation. It's the idea that if we don't link sin and suffering, if we don't link the idea of merit to illness, we find it very difficult to make sense of why illness exists, of why people get sick and die, of why they suffer. This is a way that helps us put order on this. Nietzsche talked about this. Nietzsche said that that's the genius of Judeo-Christian morality. He said the genius is that it gave a narrative to suffering. Most people think suffering is the worst thing. Nietzsche said that's not true. He said there's something worse than suffering. What's worse than suffering? Meaninglessness, nihilism, thinking there's no reason why people suffer. That's much worse, Nietzsche said. And that's what the narrative does. It gives us a reason why people suffer, why people are sick, okay? And so this is sort of my idea for one of the reasons. There's probably a lot of reasons, but this is one of my ideas for why stigma seems to be so distressingly common. Okay, so to get back to the definition a little bit, what follows from this, right? Remember, it's an in-group that marks an out-group is different on the basis of a shared demographic characteristic. Why does that matter, okay? It actually matters for a lot of reasons. What do you have to have stigma? You have to have an in-group that marks an out-group, right? Which means the in-group is what? It's actually right in the title. The in-group is what? In. The in-group is in, right? And the out-group is out, which means that stigma is fundamentally connected to social structures. Stigma is a creature of inequality. It is actually in the definition, which is partly why I think it's so important to understand the concept, right? Stigma is fundamentally connected to power structures. What this means is that disadvantaged and vulnerable groups are more likely to be stigmatized and to experience more intense stigma before they even set foot into your clinical areas, right? So are you guys members of in-groups or out-groups? Both is the right answer. A lot of times I used to, in my prior position, I did a lot of stigma teaching with nurses in particular. And that was fun because I'd always say, nurses, are you guys members of in-groups or out-groups? And they'd kind of look at me sort of the same way you guys did, and they say, well, both. And that's the right answer. Most of us, social life is complicated, most of us are simultaneously members of in-groups and out-groups all at the same time, right? However, some of us belong to more out-groups than in-groups, as you might imagine, okay? The more out-groups to which you belong, the definition of stigma suggests, the more likely you are to be stigmatized in a variety of social domains, certainly in health contexts, but in other contexts as well, in employment, in educational settings, by the way, like this one, not specifically saying KCU, but just any educational setting, right? Education, employment, housing. The history of housing discrimination is a bad history. If you don't know anything about it in this country, it's worth looking up. It's a terrible history. It's ongoing, by the way. Okay? So stigma is connected to power structures, and the more outgroups to which you belong, the more likely you are to experience stigma, and that includes in clinical settings. Right? So usually we call this compound disadvantage, right? And the idea behind compound disadvantage is, if you are, and we see this over and over and over again when we study health inequalities, right? So if you are a woman, a white woman, let's say, right, you are less likely to have your pain adequately managed than if you are a white man. And what if you are a woman of color? And what if you are an elderly woman of color? And what if you are an elderly, visibly disabled woman of color? And what if you are an elderly, visibly disabled woman of color who lives in a rural area? And so on and so forth. Okay? These things are what's called compound disadvantage. So Madison Powers and Ruth Faden, who have a model of social justice that I really like, they refer to this, I think they have a very eloquent metaphor and some language for this. They call this densely woven patterns of disadvantage. Densely woven patterns of disadvantage. And the funny thing, and I don't mean funny in a good way, but the funny thing about compound disadvantage is it's a natural fact. It's an epidemiologic phenomenon. If you are a member of a group that experiences one social disadvantage, you are more likely to experience other social disadvantages. Now, that's an aggregate finding. That's true at the group level. It's not necessarily true of every individual in that group, but at the group level, it's true. So if you are a member of a group that generally has low socioeconomic position, you are also more likely to have low educational attainment. You are more likely to live in poorer and worse neighborhoods. You are more likely to be exposed to violence of various kinds. You are more likely to experience discrimination, racism of various kinds. Right? So people get ensnared in these densely woven patterns of disadvantage that are fundamentally connected to stigma. Fundamentally connected to stigma, okay? So the idea is that stigma is a social phenomenon. We sometimes hear language and we use it colloquially, like we say, well, HIV or AIDS stigmatizes people. And one of the things I always want to do is try to correct people. That's an understandable colloquialism, but that gives a little bit too much agency to a disease process. HIV and AIDS doesn't stigmatize anyone. Who stigmatizes people with HIV and AIDS? We do. It's always people who stigmatize other people. There are some kinds of diseases and conditions, we've talked about some of them already, which are particularly active loci for stigma. So sexually transmitted infections is a very obvious one. Most people understand that pretty intuitively. Weight is another big one, okay? But it is never the disease or the condition or the mark that is stigmatizing. It's always people. It's always us who stigmatize other people. So stigma is rooted in these macro-social structures. Okay? There's my hashtag. I like to hashtag, by the way. Okay? And if you guys are interested in Twitter, you can find me very easily. Okay? I'm extremely active on Twitter, right? So that's why I express this one as noping right along. We can't do that, okay? The language is understandable, but we should be clear that it's always us who does this. This is often confusing for people. Understanding stigma as rooted in structures is really important, and that's one of the things I try to teach. We're going to get a lot of important findings from that, right? It's confusing, though, because stigma often manifests on the individual level. We don't think about it as this larger social or structural phenomenon. It usually happens because someone stigmatizes stigmatizes us, right? So someone goes to seek health care, and the healthcare provider or the care team stigmatizes them. Or they're at home and a family member stigmatizes them, et cetera, et cetera, et cetera, right? So it manifests on these interpersonal, individual levels, so we tend not to think about it in terms of structure, okay? So why does it matter? Who cares? Right? So a couple of reasons, at least I think it matters. So one reason is because stigma is actually, increasingly, we have good evidence that stigma is actually an independent social determinant of health. People subjected to persistent stigma get sicker and die quicker, even after we control for almost every conceivable confounder. And if you understand what stigma is, it starts to make sense. It's a corrosive experience, and it is not likely to be isolated, right? If you are experiencing stigma, you probably belong to an outgroup. You might belong to multiple outgroups, which means this is probably not the first time you've experienced stigma, right? You should read the stories of fat people. And by the way, when I use the term fat, people cringe, okay? So let me just say that I work on weight stigma, and I do some work with fat studies and fat acceptance and fat positivity movements, and there was an effort to reclaim the term fat, right? A lot of people in fat acceptance and fat studies movements do not like the term obesity. They consider it a medicalized term. They prefer the term fat because fat is just a descriptor, right? Short, tall, brown eyes, blue eyes, left-handed, right-handed, skinny, fat, okay? So you don't have to agree with me, and you don't have to like it, but just realize that when I use the term fat, I'm using it as a conscious political decision, okay? It's not ill thought, all right? So you should read the stories of what fat people do to prepare for a healthcare encounter. It is actually heartbreaking to me, as someone with thin privilege, right? Partly because they have experienced so much stigma in healthcare encounters for so long. Right? So it's a corrosive experience. It's not good for you. And the more, when we start to understand stigma, we would predict that. Why would it be good for you? It wouldn't be, right? So that's one reason it cares, because it's a health problem. It is a population health problem. It is a public health problem, and we should treat it that way, which means we should probably do something about it. However, here's the bioethicist, okay? Even if it didn't, even if it wasn't strongly correlated with adverse outcomes, I would want to say that stigma is generally pernicious. Right? It's generally pernicious, and what's more is, where does it track? Who's likely to be stigmatized? It's always the least well off. It's always people who belong to multiple outgroups. So you don't need to be a philosopher or bioethicist to understand that making the least well off worse is probably not something we should try to be doing as a society. That's not a good idea, okay? Probably we want to help the least well off, not make their lives worse, and stigma makes their lives worse. Okay, so I would want to say that even if it didn't have a health impact, we would probably want to do something about stigma in general. Okay, so these are the things we've talked about, the idea that there is individual person-centered stigma, which is how it often manifests in individualized encounters or in micro-level encounters. But it's really important to understand stigma as structural. And I'll talk a little bit more about what I mean by structural stigma as rooted in these upstream structures. One of the ways to understand is that stigma is scripted. Scripted. Anthropologists use the idea of social scripts a lot. They talk about it. I like this idea, right? It doesn't mean that it's destiny and that we're all destined to stigmatize each other, or that if we're privileged, we're destined to stigmatize more marginalized groups. But the idea of a script is that it's a dominant conceptual scheme into which we are acculturated, right? And that it helps to script our interactions and our behaviors even when we don't intend it. And if you guys take nothing else from this talk, maybe a definition of stigma, that would be great, okay? The other thing I would really, really like people to understand is that we stigmatize people, and I am not exculpating myself, okay? We stigmatize people all the time, even when we don't mean to. That's how stigma works. It is rooted in these upstream structures. So there are examples I give, right? If you run a primary care practice and all of your chairs are like this, what is the message you are sending to fat people? You are not welcome here. There is literally no room for you. Right? There's one story in a collection of stories that I helped to curate on fat stigma, where one of the contributors to the story, and this is public, you can actually look at this, she talked about going to the hospital and they didn't have a scale that would fit her, so she literally had to go to a junkyard to find a scale. And I think that sort of is not even a metaphor. It just sort of speaks for itself, right? If you go to a clinical setting and there are two boxes for male and female, What message does that send to gender queer, gender fluid, gender non-binary people? There is no space for you here, right? It's not intentional. I'm not saying that the people in that clinic despise trans or LGBTQ patients, or that people in these clinics actively hate fat people. That's not what I'm saying at all. Stigma is scripted. It is rooted in structures. And I'll give you guys an example of what I mean by that a little bit later, right? So this idea, it's been referred to as hegemonic, which is a fancy humanities term that just means it's invisible and it's in the background, it's there all the time. One of the ways I think about this is as the background of a play, a drama, right? What happens is you start to watch the drama unfolding and you stop seeing the background behind it. You don't see it really because you're watching the songs and the dialogue and the actors and the movement and all these other things, so you stop seeing the background. But the background, as everybody who's done any kind of theatrical production knows, is hugely important in framing the response of the audience. Even when people stop seeing it, it has a huge impact on what they experience. The same thing is true with stigma. Chronic disease stigma in particular is hegemonic. It's accepted as natural and sensible without reflection. It is often invisible. It is often baked into social structures. So I'll give you guys a couple examples of what I mean by this. Right? So Australian healthcare providers in 2013, they surveyed them. They said that type 2 diabetes is one of the least stigmatized conditions. Then they asked the patients. What do you think the patients said? 93% of the patients reported experiencing stigma. Okay? So, another example, and I think this is a great and terrible example, is there's a really tremendous, horrible study, and it's tremendous because it's great. It's horrible because of what it actually shows. That came out in 2016 on pain. We have terrible problems with pain stigma, as far as we know, right? Terrible problems with stigmatizing people in pain in this country. And so this study, what it did was it basically took a study of medical students, people like yourselves, okay? And it basically gave them a questionnaire. And the questionnaire had a whole bunch of false beliefs about people in pain. And these false beliefs were racialized beliefs, right? So one of them said something like, black people are less sensitive to pain than white people. So it had a bunch of things like that. And then it had a bunch of true statements, by the way. And then they gave the participants who were medical students. This is a study of students at the University of Virginia. Right? They were medical students. Then it gave them a clinical vignette and asked them how they would treat the patient. And even though treating chronic pain in general is very difficult, this was a clinical vignette that they had vetted by clinicians. This is a clinical vignette when there was a right answer. Right? There was definitely one thing that you should do. This was not an ambiguous case. And they carefully vetted it that way. And then what they looked at was whether or not people's percentage of false beliefs correlated with how well they would do in treating pain. And guess what they found? Wild guess. A great correlation. A strong correlation. The more false beliefs you had about racialized bodies and pain, the less likely you are to treat it effectively. Deep, old structures, by the way. Here I speak as a historian. Those beliefs about black bodies and brown bodies in pain are old in our society. Old by white United States standards, okay? I mean, no, it's not old by, time moves differently for different cultures, right? But so we're talking about at least 150 to 200 years old. Those structures are old, and they still continue to have a real impact on how people are actually treated when they experience. This is the idea of disease stigma as hegemonic. If you actually went and polled those participants, how many of them do you think would stand up and say, I hate people of color? Right? They don't. That's not the way stigma works. Its scripts are interactions, even when we don't intend it. And that's one of the things that's powerful about stigma, okay? It can be devastating for marginalized groups. The way that we act reifies, it gives life, it perpetuates these structures and scripts even when we don't intend it. And that's usually the way that stigma happens. It's also integrated into laws and policies. And here I speak as a public health law scholar. So I'll give you guys a great example. And again, this is pain, okay? So the CFR, which is a code of federal regulations that governs award of Social Security benefits. Say you're seeking Social Security benefits. What do you have to show? You have to show that you have to show a number of different things, but one of the things that the CFR says is that your statements alone are not enough to establish that there is a physical or mental impairment. What's the problem for people with chronic pain? What do you have? How do you diagnose pain? Is there a test? X-ray? MRI? Blood test? What other tests do you guys use? Keep going. Anything? No. How do you diagnose and treat people in pain? What do you rely on? The patient, the American Pain Society. The patient's self-report is the single most reliable indicator of pain. A clinician needs to accept and respect this self-report absent clear reasons to doubt. So you can find this exact same language or something very similar on the first page of almost any professional society in the United States whose practitioners treat pain. You can find it in any handbook of pain management. And yet, right, we see on the left this regard for people treating people differently who are pain. So does this Code of Federal Regulations, does this provision sustain and fuel stigma? My argument would be yes, that's my belief, but does it fit the definition? Does it mark a group of people, an outgroup as different on the basis of a shared demographic characteristic? Yes, it does. It marks people in pain as different on the basis of their pain. Does it regard them, does it assign some notion of deviance, some negative assignation on this basis? Yes, it does. Right? It makes it harder for them to get an entitlement to which they might otherwise have a chance of acquiring. It treats them differently. So it reflects and fuels pre-existing stigma against people in pain, right? Some other things to talk about that often come up when we talk about stigma. Oftentimes one of the questions I say is, well, what about health behaviors? What about people who do things that we know are not good for them, right? Risky health behaviors, right? And so there's a number of things to say here. The most important one is the one that public health people, I think, talk about quite a bit, which is the social patterning of health behaviors. We know that health behaviors strongly track social gradients, right? So if you are a member of a marginalized group, you're not just more likely to have worse outcomes. You are, that's definitely true, but you're also more likely to engage in risky health behaviors. Like what? Who smokes more, poor people or rich people? Poor people, right? Who engages more in substance abuse? Poor people or rich people? Qualification, opioids, right? But in general, poor people or rich people? Poor people, right? Who engages more in risky sexual behaviors? Poor people or rich people? Poor people. So why? Are poor people dumb? Do they just not know? Do they not know these things are bad? What do you guys think? Usually when I say are poor people stupid, there's like no, I don't think so. No, I don't think so. Of course not. I mean, I can't believe that there's any much of a difference there between poor people and wealthy people. The answer, it seems to be, and we're not really sure how and why this happens, but it looks like there's something generative about risky health behaviors that seems to track disadvantage. The more disadvantage you have, it seems like the more likely you are to engage in risky health behaviors. There's something about living in adverse social conditions that seems to make it more likely. So there are a number of theories as to the mechanisms by which this works. Ideas of hopelessness, right? There's one memorable study from where I was living for the past, for 6 or 7 years in eastern North Carolina. It's a study of promiscuity among teenagers in a severely economically depressed town in eastern North Carolina. It's an anthropologic study, so it's an ethnography, so there's a quote, as is usual, in the title. And the title, the quote from one of the informants, and you can actually look this up on PubMed, which is one of the reasons I think it's amusing, is, when you got nothing to do, you do somebody. It's actually a title, right? So behaviors are powerfully socialized, very, very powerfully socialized, right? And the more marginalized, the more stigmatized you are, the more likely you are to engage in these kinds of risky health behaviors. But there is also a risk, and this is one of the risks, right? We talk about this a lot, especially with some of my public health learners, is that individual agency still matters. Even people living in straitened social circumstances often have some ability to make better or worse choices. Right? And if you think about it, it would be really bad if we said that all their choices were completely socially determined, because then what would we be doing? We'd be taking disempowered and marginalized groups and telling them what? We'd be further disempowering them. We'd be saying, oh, nothing you do matters. You're trapped in these densely woven patterns of disadvantage. Good luck. Sucks to be you. I can't help. Right? So that's not so good. We want to be sure to preserve some measure of agency, and there's